Welcome to the Deep Dive. Today we're really getting into something super common, corneal abrasion.
Yeah, that scratch on the eye. Happens all the time, doesn't it?
It does, and we're going to use our revision notes today to make sure, you've got the essential info nailed down.
Exactly. Think about maybe you rubbed your eye a bit too hard or felt that sudden sharp feeling. That's often what we mean. It's an injury right on the front surface.
Right, the cornea, that clear bit at the front.
Precisely, the outermost layer.
Okay, so even though it might sound minor, looking at these notes, there's actually quite a bit to cover, especially if you're revising.
Definitely.
So our mission today, break down these corneal abrasion notes, pull out all the crucial bits, causes, complications, everything, and hopefully make it stick.
Sounds good. So that definition first, let's just lock that down. Corneal abrasion, a scratch, an injury to the cornea, that outer layer.
Simple enough.
But it's amazing how much we rely on that tiny surface for, well, seeing clearly. So even a small scratch can really cause problems. Discomfort, blurry vision.
Okay, so what usually causes them? What are the common culprits?
Well, the notes talk about etiology, fancy word for causes. And the biggest one, number one, is trauma.
Right, like getting hit in the eye.
Sort of, but often much smaller things, like getting a foreign body in there, bit of grit, eyelash, dust. Fingernail scratches happen a lot too. You wouldn't think it, but yeah.
Just rubbing your eye.
Could be. Or, contact lenses. Issues putting them in, taking them out, or maybe the lens itself causes irritation. That's a big factor for lens wearers.
Makes you think, doesn't it? Is that it for causes, or is there more?
There's a bit more. Exposure to irritants like chemical splashing, that can damage the cornea.
Right.
And sometimes infections, corneal infection, they can lead to abrasions too.
Yeah.
Oh, and dry eye syndrome. If your eye isn't well lubricated, it's easier to scratch.
That makes sense. A dry surface is more fragile.
Exactly. And lastly, sometimes people have underlying corneal problems, disorders, that make their cornea weaker and more prone to this kind of injury.
So it's not always just a direct, obvious injury. Sometimes it's the eye's own condition. Is there a way to remember those causes easily? A mnemonic, perhaps?
There is, actually. The notes suggest thinking 4 T's and 2 D's.
Okay, 4 T's, 2 D's.
Right. So trauma, that covers the foreign bodies, the fingernails, the contact lens problems. Then things just to really hit home those foreign bodies.
Got it.
Touching, like rubbing your eye. Tears, that links to the contact lens issues. Lubrication, maybe. Then the 2 D's. Dry eye and disorders, those underlying conditions.
4 T's, 2 D's. Trauma, things, touching, tears, dry eye, disorders. Okay, that's helpful. It covers the range, doesn't it?
Yeah, from the sudden impacts to the more chronic issues.
So who's more likely to get these? Are there specific risk factors we should know?
Definitely. The notes point out a few things. High-risk activities are one, think sports, especially contact sports, if you're not wearing eye protection.
Yeah, makes sense.
And certain jobs, occupational hazards. Construction work, for example. All that dust, potential for flying bits of material.
Clear risks there. What about less obvious things?
Well, back to contact lenses, incorrect use is a major risk factor.
Like wearing them too long.
Exactly. Or not cleaning them right, handling them roughly when you put them in or take them out. And dry eye syndrome pops up again here as a risk factor.
It seems quite important, the dry eye aspect.
It really is. A dry surface just gets damaged more easily. And like we said before, if someone already has a corneal condition, they're naturally more vulnerable.
Okay, so it's a mix of what you're doing and how healthy your eyes are generally. So let's say it happens. The scratch occurs. What's actually going on at the microscopic level, the pathophysiology?
Right. So that abrasion, it breaks that smooth outer layer, the epithelium. Think of it like the skin on your arm or maybe the lining inside your mouth. It's a barrier.
Your protective layer.
Exactly. And it regenerates quickly, but when it's broken, it exposes the nerve endings underneath. That's why it hurts, often quite a lot.
Oh, okay.
Then the body reacts. Inflammation kicks in, which can make vision blurry temporarily. The good news is that epithelium usually heals incredibly fast.
But there's a catch.
Well, yes. If the scratch gets contaminated, say with bacteria, or if it's quite deep, then you risk infection. And that's a more serious problem.
Right. So that barrier is key for protection and comfort. Now, someone comes in, eye pain, redness. How do you figure out if it's just an abrasion or something worse? What else could it be? The differential diagnosis.
This is really crucial because some things look similar but are much more serious. The notes give a good list. First, you've got to consider open globe injuries.
Like the eye has actually been penetrated.
Precisely. A major red flag there would be if the eyeball looks distorted, not its usual shape. Then there's a corneal ulcer, microbial keratitis.
An infection.
Yes, an infection causing an ulcer. You'd especially think of this in contact lens wearers. Or if there wasn't a clear story of trauma. It often looks different, too. Maybe a visible white spot or infiltrate on the cornea.
Okay, those sound serious. Need to roll those out fast. What else?
Well, there are dendritic ulcers. They look like little branches, characteristic of the herpes simplex virus affecting the eye.
Herpes in the eye.
Yeah. Then you've got things like acute glaucoma, sudden high pressure inside the eye. Uveitis, scleritis, these are inflammations of different parts of the eye, often more widespread redness or other symptoms.
Okay.
Also need to consider chlamydial conjunctivitis or herpes zoster ophthalmicus, that's shingles affecting the eye area, often with a rash. Orbital cellulitis is a nasty infection in the tissues around the eye.
Wow, that's quite a list.
And then, of course, simpler things causing a red eye, like basic conjunctivitis or episcleritis.
How on earth do you remember all of those when you see a patient with a red sore eye?
It is a lot. The notes suggest a mnemonic. Go ducks choose. It's a bit strange, I know.
Go ducksies. Okay, let's hear it.
Glaucoma, open globe, dendritic ulcer, the corneal one, conjunctivitis, scleritis, herpes zoster ophthalmicus, orbital cellulitis, episcleritis.
Huh. Go duck us choose. It is weird. Maybe weird enough to stick.
Hopefully. The point is, you need to think broadly and rule out the dangerous stuff.
Definitely. Now, practically speaking, how common are these corneal abrasions? What's the epidemiology like in the UK?
The notes say that exact UK figures aren't super well defined, but the general consensus, very common.
Yeah.
It's one of the most frequent eye injuries people present with, really across all ages. So yeah, you'll definitely see it.
Good to know. So when someone does have one, what do they typically complain of and what might you actually see? The clinical presentation.
Okay, symptoms-wise, eye pain is the big one. Often sharp, feels like something's in the eye, that gritty foreign body sensation.
Yeah.
Lots of watering, tearing. Redness is common. Sensitivity to light, photophobia. And vision might be blurred. Sometimes you might even be able to see the scratch if you look really closely.
Sounds pretty uncomfortable. So during an exam, what points towards a simple abrasion?
Well, using a slit lamp, that special microscope, you'll likely see redness, maybe what's called ciliary injection, which is redness concentrated around the colored part, the iris. But the key diagnostic tool is fluorescein dye.
Ah, the yellow dye.
Exactly. You put a drop in and shine a blue light, and any break in that surface layer, the epithelium, just lights up. Glows yellow or green. It shows you exactly where the abrasion is, how big it is. Could be a line, a dot, a whole area.
Okay, and what about those red flags we talked about? What signs would make you worry it's not just a simple abrasion?
Right. Critical signs. The notes list things like a deep cut on the eyelid, significant bleeding under the white part, the conjunctiva, or an actual tear there, any weird shape to the pupil or changes in the iris. A positive Seidels test, that's where you see fluid leaking from the eye showing a hole. That's an emergency. Also, if the eye movements are restricted, if the eye looks like it's bulging out or sunken in, or any obvious sign something has gone into the eyeball.
Yeah, all definite uh-oh moments needing immediate action. The notes also mentioned photokeratitis or arc eye. What's specific about that?
Ah, yes, arc eye. That's basically sunburn of the cornea, usually from UV light, like welding without goggles. The key thing is the delay. Symptoms, pain, redness, light sensitivity don't start right away, usually 6 to 12 hours later.
Interesting.
And when you examine them, you might see swollen eyelids, general redness, maybe the cornea looks a bit hazy, and often you see lots of tiny little dots on the cornea's surface staining with fluorescein. That's called punctate keratitis. The history of UV exposure is obviously vital there.
So asking the right questions about how it happened is really key.
Absolutely crucial. A patient comes in with sudden eye pain, redness, feels like something's in there. You need to ask, what were you doing? Any chance of metal hitting the eye? Grinding? Welding? Contact lenses? Any previous eye problems? That history helps narrow it down massively.
Makes sense. So moving on to investigations, you've mentioned the slit lamp and fluorescein. Is that usually it for a typical abrasion?
For most straightforward, superficial abrasions, yes. A good clinical exam with the slit lamp and that fluorescein staining is usually all you need.
So not loads of complex tests usually.
Generally not, but if there's been significant trauma, like a punch or a fall hitting the eye area, and you suspect maybe an orbital fracture, or if you think there might be a foreign body inside the eye, then imaging is needed.
What kind of imaging?
CT scan of the orbits is the go-to for looking at fractures and foreign bodies within the eye or socket. Plain x-rays. Not so useful generally. Maybe only if you strongly suspect a metal foreign body that would show up. And MRI, usually a no-no if you suspect metal because of the strong magnet.
Right, safety first. Okay, diagnosis made. Corneal abrasion, how do we manage it? What's the standard UK approach?
Okay, management goals are pretty clear. Help the cornea heal, make the patient comfortable because it can really hurt, and importantly, prevent infection.
Makes sense. How do we do that?
Usually involves antibiotic eye drops or ointment. Chloramphenicol is often the first choice. Fusidic acid is an alternative.
Antibiotics just in case.
Yeah, prophylactic to stop bacteria getting a foothold in that broken surface. If the patient wears contact lenses, you might use something with better cover against Pseudomonas, a bug more common with lens wear.
Okay. And for the pain and discomfort?
Pain relief is vital. Lots of lubricating eye drops, artificial tears. They soothe the eye, keep it moist, help healing, and just feel better.
Like creating a smoother surface.
Exactly. And you can use pain relief drops like topical NSAIDs or just oral painkillers, paracetamol, ibuprofen. One thing the notes mention is eye patching.
Do we still do that?
Generally, no, not for simple abrasions. It used to be common for comfort, but evidence suggests it might actually slow down healing and doesn't really help pain much. It might hide problems, too. So usually avoid it now, unless maybe in very specific cases for a short time, but that's less common.
Good to know. So antibiotics, lubricants, painkillers. When does this simple abrasion need escalating? When do we need urgent referral to ophthalmology?
Right, crucial to know when to call for help. The notes say refer urgently if symptoms are getting worse, not better. If there's no real improvement after, say, 72 hours, if you think there's a foreign body still in there that you can't or shouldn't remove yourself.
Okay.
Also, if there's a rest ring on the cornea, that means a metal foreign body was there. If the patient gets recurrent abrasions, ones that keep happening, obviously any suspected penetrating injury,
Right.
and chemical burns acid or alkali, that's a definite emergency. Oh, and high velocity injuries like from machinery.
So quite a few triggers for urgent referral. You mentioned foreign bodies and rust rings.
Yeah.
How are they managed specifically?
Well, if it's a superficial foreign body and you're trained and have the right kit, you might be able to remove it carefully. But if it's deep or you're unsure, refer. Rust rings need an ophthalmologist to remove them, usually with a special tiny drill, a burr. And those recurrent abrasions often need specialist input to figure out why they're happening and how to stop them.
Right. Definitely a case of knowing your limits. So for the straightforward ones that are managed well, what's the outlook, the prognosis?
Generally, really good. That's the positive message. With the right treatment started promptly, most simple corneal abrasions heal up completely within a few days, maybe up to a week. Usually no lasting impact on vision.
That's reassuring. Are there any potential downsides? Complications?
They're not common if treated well, but yes, complications can happen. One is scarring. If the abrasion is deep or gets infected, it can leave a scar on the cornea. If that scar is in the middle, over the pupil, it can affect vision.
Makes sense. Anything else?
The other main one is something called recurrent corneal erosion syndrome. This is where the top layer, the epithelium, doesn't stick down properly after healing, so it can just shear off again easily. Often happens when waking up, opening the eyes in the morning. Very painful and needs specific management.
So getting that initial healing right is pretty important. Finally, prevention. Can people do anything to avoid getting these in the first place?
Absolutely. The biggest thing is eye protection. Simple as that. Wearing safety glasses or goggles for risky activities, sports, DIY, gardening, certain jobs, it makes a huge difference.
Common sense, really.
It is, and maybe protecting eyes from strong UV light, like wearing proper sunglasses, helps general corneal health, though that's more directly linked to preventing things like photokeratitis.
Good advice. Okay, so let's quickly sum up this deep dive on corneal abrasion. It's a scratch on the eye's front surface, the cornea, usually caused by minor trauma, things like grit or fingernails or contact lens issues.
Right, and while it's usually painful and causes symptoms like watering and light sensitivity, it typically heals well with simple treatment.
Key is using fluorescein to see it, giving antibiotics to prevent infection, lubricants for comfort and healing, and pain relief.
And knowing those red flags, knowing when it might be something more serious, like an open globe injury or an ulcer, and when to refer urgently.
Absolutely. But for most people, the prognosis is excellent. Quick healing, no long-term issues.
Exactly. The cornea is amazing at healing itself, usually.
So here's something to think about. Considering just how common these minor eye injuries are, what simple, maybe almost effortless changes could we all integrate into our daily lives to dramatically cut down our risk of getting a corneal abrasion? Definitely food for thought.
Good question.
And for anyone listening who wants to delve deeper or needs more top-notch resources for MSRA prep, make sure you check out passmsra.com and also freemsra.com. Lots of great stuff there.
Definitely worth a look.
Thanks for joining us on the Deep Dive today.